Hello, everybody. My name is Jason Kim, and I'm the Director of OA Research Programs here at the Arthritis Foundation. OA and specifically clinical research in OA has been an area of growth for the Arthritis Foundation over the last decade. I joined the foundation earlier this year and have been charged with organizing our efforts in OA clinical research. This includes the work of bringing together this community of researchers and investigators to help drive conversations about progress toward new therapies in OA clinical research. One big way we're trying to elevate OA research is by organizing public discussions such as these. And today we have Dr. Nancy Lane presenting Tanezumab and similar emerging therapies. We've also had in June, Does Strong Muscle Matter in OA with Eva Roos, in July, RA Biologics in OA with David Felson, and next week's discussion will be Cell Therapy in OA with Scott Rodeo. We hope in this way and through a future Arthritis Foundation clinical research conference that we can bring focused attention to contemporary topics in OA clinical studies. So thank you for joining us in today's digital discussion for the Arthritis Foundation's inaugural OACS Forum Series. It's been an enormous pleasure working with David Felson, Nancy Lane, and this wonderful panel of experts on today's topic. David is also one of our overall Forum Series chairs, along with Martin Lutz. Both have been extremely generous with their time and expertise, and I depend on them constantly for guidance. Before I pass to David, I want to remind everyone for a few housekeeping items. OA is a disease without borders, and we are proud to include many nationalities on this call. So we make this program available to people in all corners of OA research, and this program is being recorded, and links will be posted on our website in the coming weeks. Attendees can also submit questions to the panel during the discussion and presentation via the Q&A chat function, but are otherwise muted. We will be looking for your questions for the panel to address in the discussion. We just ask that you rename yourself appropriately so you'll be properly identified and credited with the question. We may also ask you to turn on your mics and video and ask the question yourself. If at any time you have any technical issues while on the Zoom call, please send an email to afscience@arthritis.org. Our staff will be monitoring the email line. Also, after the discussion, we'll be having a networking breakout session hosted by one of our patient volunteers, Patrice Johnson, immediately after the call. So it's a chance to network with other participants and attendees. So I hope you'll take the chance to say hi to your colleagues. And if you do share this event on Twitter or other social media, feel free to add your media handles into the chat box, and you can also use hashtag AFOACS to help us share. And so now I'll pass off to David.
Okay. Thanks, Jason, and thanks for organizing this and doing such a wonderful job of doing that. Let me introduce Nancy Lane, a colleague and friend who is an endowed professor of medicine, rheumatology, and aging research at the University of California, Davis, and director of the Center for Musculoskeletal Health there. She's also the first author of a really pivotal study in the New England Journal on Tanezumab and its effect on osteoarthritis pain. And she is the host and organizer of this workshop. So I wanted to turn the mic over to Nancy to run this.
Thank you, David. Thank you, Jason. And thank you for my panelists who've agreed to spend some time today talking about Tanezumab and emerging similar therapies that are emerging. Yeah, next slide, please, Jason. Okay. What we have is a very, very exciting program this morning, international in its speakers. We're going to have 4 panelists that are going to speak for a few minutes each, providing data related to Tanezumab, and also understanding pain and its relationship to osteoarthritis, to then understand how Tanezumab and similar therapies can help to reduce the pain. This is our schedule. Now, my panel members are well known, and I'm honored to have them speak today. Dan Clauw from the University of Michigan has really focused his entire career on trying to improve understanding and trying to improve pain in patients with arthritic diseases. Marc Hochberg, an internationally known expert in osteoarthritis. And Marc will explain some of the efficacy and the challenges with this new set of anti-NGF therapies. Anne-Marie Malfait from Rush University will discuss osteoarthritis and what causes the pain. And David Walsh from the University of Nottingham has spent quite a bit of time trying to understand pain and osteoarthritis and how this new set of therapies inhibiting NGF could actually work. After that time, there'll be an ability for everyone who's listening to ask questions in a chat room. So write your questions down and send them in, and the panel will do their best to answer them. So the title of our seminar and our meeting today is an update on nerve growth factor inhibition for the treatment of painful large joint OA. And as I mentioned, we're going to be able to go from the bench to the bedside and actually beyond with the help of my esteemed speakers. So first, I will give you a little bit of a background on nerve growth factor. It was discovered a number of years ago, and to understand its importance was one investigator from Italy and one investigator from the University of Washington University in St. Louis received the Nobel Prize for the discovery of nerve growth factor. And it was isolated, and we're going to refer to nerve growth factor as NGF quite a bit in this talk. So I'm going to go ahead and start with that by saying NGF was isolated back in the 1950s, which makes it close to 70 years ago, through observations that certain cancerous tissues could cause extremely rapid growth of nerve cells. So here you go, you got a cancer that's proliferating cancer cells, and at the same time is something's happening to cause nerve cells to grow. And then these investigators, through some very elegant experiments, determined that NGF was critical for the survival of small, mainly peripheral sensory neurons and sympathetic postganglionic neurons during development. Then in further experiments, it was found that NGF was quite active in adults in what we call nociceptive neurons that are well characterized and not appreciated until many years later, that these were the nerve cells that NGF was helping to proliferate. So we're going many, many years, now we're going 70 years forward, and what we have is a pretty good understanding, and you'll learn a little bit more about that this morning, that this nerve growth factor attaches to a receptor that we're going to call TrkA. And it actually gets taken up, the NGF gets taken up by its TrkA receptor and travels to neurons that then translate this message into pain. And today we're going to learn about NGF, we're going to learn about the bit about the TrkA receptor and how modulating both of those has been studied to inhibit the pain, especially of osteoarthritis. So I'm now at the topics that we're going to talk about today is the basic biology of NGF and pain, the basic biology of NGF and translation to clinical OA, a brief review of the clinical studies of the anti-NGF treatment for large joint OA, and a thorough review of the safety of anti-NGF antibodies from the clinical trials. That's quite a bit that we'll cover, and after that, we'll have a panel discussion. So stay with us, and we're quite happy to have you all with me. And now I will reintroduce Anne-Marie Malfait from Rush University, who is an international expert on understanding the pain of osteoarthritis. So please, Dr. Malfait, welcome and go on.
Thank you, Nancy. I hope that everybody can see my screen and everybody can hear me. And I would like to thank the organizers, David, Felson, and Jason, for inviting me here, and Nancy. And so I will give a brief overview of osteoarthritis and the associated pain by way of introduction of David Walsh, who then right after me will dig deeper into mechanisms of NGF in the course of pain in osteoarthritis. So as you can see, I'm located in Chicago, here at Rush. The building in the forefront here is Rush University, where I'm currently sitting in sunny Chicago. So these are my disclosures. So we're going to spend the morning talking about osteoarthritis, and many of you have seen this quote before. We all know that osteoarthritis is currently still, unfortunately, when it comes to therapies, a barren field with a small harvest, and that's causing some people into a drowsy despair. However, I always add that we should keep in mind that other body parts may preoccupy younger men, but by middle age, men have their knees on their mind. And so why is that? That's because worldwide osteoarthritis is one of the leading causes of disability and chronic pain. Arthritis is the most common cause of joint pain, and osteoarthritis is actually the most common form of arthritis. And in the most recent global burden of disease published in the Lancet, osteoarthritis ranked as the third most rapidly rising condition associated with disability after diabetes and dementia. So an enormous problem, and a problem that is expected to increase with the aging of the population and the rise in obesity, which are amongst the major risk factors for osteoarthritis. And in fact, the estimated number of adults in the US alone with doctor-diagnosed arthritis, and that's for the largest part osteoarthritis, is projected to increase to nearly 67 million by 2030. And it's associated with increased comorbidity and increased mortality. So this is a serious problem. And unfortunately, the management options currently for osteoarthritis are limited. So the go-to painkillers are NSAIDs and acetaminophen, and they have small effect sizes that are similar to placebo. Their prolonged use comes with side effects, major side effects. Things like exercise, weight loss strategies do actually have an effect, but they're very difficult to implement. Currently, we have no treatments that alter structural progression of joint damage. And for large joints, the replacement surgery is considered the definitive treatment, although in several studies, anywhere between 10 and 30% of people after a knee replacement still have pain and functional limitations. So in the next slide, what you see here is really a drug development timeline for the discovery and development of D-modes and novel analgesics. And so a D-mode, a disease-modifying drug for osteoarthritis, is defined as a drug that inhibits progression of structural joint damage and will also improve symptoms and/or function. And so it is a very long path to get there. And unfortunately, as of now, there have been no D-modes approved by the FDA or anywhere in the world for the treatment of osteoarthritis. This is an older slide. It's about a year old now. And so it's not for lack of trying. There have been very many, and there are many very appealing targets that are being developed for their potential D-mode effect. As I said, this slide is about a year old. controlled, and unfortunately several of these have been stopped. Most recently, the senolytic agent here by Unity Biotechnology, the development of this was stopped. Others are still very much going forward, such as the Wnt beta-catenin antagonist loricivivint by Samumed, an aggrecanase inhibitor by Galapagos. So these, and also anabolics such as FGF18. So these are going forward. These are really meant to be disease-modifying drugs for osteoarthritis. So let's have a look at what osteoarthritis is. When we think of osteoarthritis, we think eroded cartilage, which you can see here on the patella and the femur. The end stage, we see X-rays, radiographic changes, joint space narrowing, subchondral bone sclerosis, osteophytes that are being formed. Those are bony spurs that are the result of bone remodeling. So we are all very well aware that osteoarthritis, we think of it as a disease of the joint as an organ, where all the tissues in the joint really participate in the disease. So there is synovitis, there are changes in the menisci, there are changes in the subchondral bone, there is bone remodeling with osteophytes. That's the pathology of osteoarthritis. But for a patient, this is what osteoarthritis is. It's pain and it's disability. And in fact, in 2017, the Arthritis Foundation organized a patient-focused drug development meeting in parallel with a similar initiative by the FDA. And so the report there you can find on the Arthritis Foundation website reflects the perspectives of patients and their caregivers. And really, pain and tenderness were identified as having the most significant impact on the daily lives of participants. And they repeatedly described that they really have to make a lot of changes to their lifestyles on a daily basis to avoid pain with osteoarthritis. And so that's the topic of today's discussion, is that there is actually the approval of a novel painkiller that targets the nerve growth factor that Nancy Lane introduced, and the approval of that is expected to happen before the end of this year. So if we have a look at the anatomy, the basic anatomy of pain and joint pain, then really, so the pain originates from the joint, and the pain is sensed by specialized sensory neurons that are called nociceptors, and they innervate the different tissues in the joint. And when they are stimulated by a painful stimulus, then they will take the signal in the form of an axial potential to their cell body, which is located in the dorsal root ganglion. And then the signal will be taken further into the central nervous system, in the dorsal horn of the spinal cord, where the first synapse occurs. And then the signal will go into the brain, and then it will further be modified in the brain, and it will be perceived as pain in the brain. So that's the basic template. And then what happens is that in the course of inflammation and tissue damage, what happens is that this whole pain pathway sort of goes on high alert, and it gets what's called sensitized. And this can happen in the periphery by mechanisms that are causing peripheral sensitization. So now what happens is that stimuli that are shouldn't really be painful are also picked up and are actually transmitted through this system and are being perceived as painful. And then there are also very different mechanisms that are happening in the dorsal horn and in higher levels of the brain that are causing central sensitization. So sensitization is very much part of this. So when we look at this again, and we look at osteoarthritis, we should always keep in mind that it's really a chronic progressive disease that can progress over years and often even decades to lead to this end result of a severely damaged joint. And how fast this goes, this progression goes, is influenced by different factors, a lot of mechanical factors, joint alignment, overuse, genetic factors, systemic factors such as obesity. But when we look at pain will also progress over time. And typically the pain in osteoarthritis is insidious in onset. People will have episodes of pain and then long pain-free episodes. The pain is very typically activity related, especially in the beginning. So people will say that their knee hurts when they are going up the stairs, for example. pain can also start radiating outside of an affected joint. The pain can become persistent. The pain can even, in severe cases, become pain at rest, and people will say that they will wake up in the night with severe bouts of pain. And then there are also all sorts of signs of sensitization that are detected in patients with osteoarthritis when people actually study those. And those are neuropathic elements, such as people will say there will be burning or tingling pain, and there will be neurosensory changes that are indicative of sensitization, such as reduced pain pressure threshold. So somebody can put pressure on the knee and that will hurt too much, but one can even have knee osteoarthritis and put pressure on the wrist, say, and that will have reduced pain pressure thresholds. So these are all indicators of sensitization. And again, there are many factors that will determine and will influence how this progresses. So really, these are these two things that are going on. And unfortunately, we do not know exactly how all these things relate to each other. Because pain is an incredibly complicated phenomenon. So when the knee hurts and has this nociceptive drive that goes into the dorsal root ganglia and then further, this can be modified by things such as catastrophizing, anxiety, sleep problems, depression, and more it's becoming very clear that whether one is male or female is a very big determinant in how all these things are being processed. So it's a very complex phenomenon. On the other hand, we have very good evidence that in osteoarthritis joint pain specifically, there's a very strong peripheral drive. And so this here lists this clinical evidence. So we know, for example, in studies that intra-articularly administered local anesthetics such as lidocaine can alleviate pain. We also know that in the vast majority of cases, total joint replacement will offer pain relief and also normalize sensitization. And then today's topic is that, as you will hear, antibodies that are peripherally active against nerve growth factor show pronounced analgesic effect. And then lastly, we also in recent studies, and a lot of those were done by Dr. Felson and his colleague Tuhina Neoji, that specific joint pathology has been associated with knee pain and sensitization. And that's captured in the next slide, which was loaned to me by Dr. Neoji. So bone marrow lesions, which you can detect on MRI, are associated with pain and with fluctuations in pain, but they are not associated with sensitization. On the other hand, inflammatory signs such as synovitis or effusion that you can pick up on MRI are actually associated with sensitization. Okay, so when we look at, I will not talk about animal models, but what we are in our lab, we are studying animal models and we are looking at chronic progressive animal models of osteoarthritis in mice. And what we are really seeing there, that there are a lot of changes that are going on in the joint, but we can also pick up a lot of changes in this pain pathway. So as the disease progresses, the milieu in the joint changes. There is synovitis, there is cartilage degradation, there is bone remodeling. At the same time, we can pick up specific changes in the cell bodies of the dorsal root ganglia. For example, we see that NGF message is being produced here in the DRG in a very temporal, in a temporal specific manner. We also see that macrophages will come into this dorsal root ganglion. So there is inflammation in the pain pathway. And we also see in the dorsal horn here that there is activation of microglia in later stages of disease. So what causes, if we focus on the joint, what could cause this sensitization of the nociceptors that are in the joint? Well, a lot of things. So I think a lot of people people often do not realize that nociceptors, just like immune cells, express really a very wide variety of receptors. They have receptors for cytokines. They have GPCRs that will bind chemokines such as MCP1. They also have all these ion channels. They have toll-like receptors, so they can bind damage-associated molecular patterns. And they, importantly, also have TRK, the receptor for nerve growth factor. So when there is joint remodeling and there's inflammation going on, there are a whole host of molecules that can be produced locally in the joint that can activate and sensitize these nociceptors. And here I can show you briefly an experiment where we injected nerve growth factor into the knee of a healthy mouse, and then we look at, we can press the knee of that mouse here with this little transducer, and we can see that the mouse withdraws its knee. And that's not happening so much when you inject actually a saline into the knee. So this is showing that we can induce a sensitized response to pressing the knee when we inject nerve growth factor into the knee. And so we can also pick this up by imaging the dorsal root ganglia. And so you will actually see that certain cell bodies will react to the injection of the NGF. And that is what we see here. We can actually see that in the course of osteoarthritis, these are mice with osteoarthritis compared to control mice, that they will respond more to nerve growth factor. Now, we actually, surprisingly, we do not know all that much about where nerve growth factor is in joints with osteoarthritis. The precise expression patterns of NGF or the TRK receptor in healthy joints and joints with osteoarthritis has not been well documented. We know that there is message for NGF in the chronic phase of mouse models in the cartilage, and there is one paper that has shown NGF protein in the synovium. And I've already shown we can also detect it in dorsal root ganglia. And Dr. Walsh will talk about that a little bit more. His lab has done nice work where they really looked at levels of NGF in human synovium. And he will show this later. There are a couple of papers out there that look at synovial fluid and serum levels of elevated nerve growth factors in patients with osteoarthritis compared to control. And in one paper, this has been correlated with poor knee function. So we do not actually have that much information on this. So I just want to end with one more piece of information, and that is that, so it's known that NGF can sensitize nociceptors, but as Dr. Lane mentioned in her introduction, NGF was discovered because it can actually make nerves grow. So we started looking at where nociceptors may be in mice and in joints of mice. And so for this, I don't have to go into the details, but we made these tomato reporter mice. And so these mice express a bright red fluorescent reporter in all nociceptors. So all the nociceptors will be red in these mice. And really, we can use these mice to then really beautifully look where the nociceptors are. Here you see the nerve bundle itself. Here you see the dorsal root ganglia. You see all the nociceptor cell bodies. They are the small to medium-sized cell bodies, which is typical for nociceptors. Here you can see all the red, how the nociceptors are entering into the dorsal horn of the spinal cord. So the question that we ask here, where are they in the joint? Because we don't actually have very good information on that. And I'll just give you an example. This is a healthy joint. So this is a healthy mouse joint. We see a lot of red in the bone marrow spaces, but apart from that, it's actually quite uneventful. I have to go through this fast, but we have published that if you want to look at it in more detail. But this is the medial compartment of a murine joint with osteoarthritis. And what we then see is that we actually see this nerve growth here in the medial synovium as well as in the medial meniscus. And so if we quantify this, we can actually see sprouting of nerves in the medial synovium and in the medial meniscus in mice with osteoarthritis. And importantly, we also actually see, and Dr. Walsh will talk about this more, we can see that in these mice, there are these channels that are being formed in the subchondral bone that make their way towards the articular cartilage. And in these channels, we can really see the sprouting of nociceptors. And again, here you can see this quantified. So just to wrap it up now, in summary, I've shown you some clinical evidence that peripheral nociceptive input is a major drive for pain in osteoarthritis. Sensitization is a part of the pathogenesis of pain in osteoarthritis, and NGF has sensitizing effects. And then lastly, we should keep in mind that in a joint with osteoarthritis, there is tremendous plasticity of the nervous system. And we should always keep in mind that a joint with osteoarthritis has a nervous system and an innervation that is completely different from that of a healthy joint. And so this is really part of the OA pathology, and what the role of nerve growth factor in that is something that we currently do not know. And so I will end here. I would like to acknowledge all the people in my lab for their work, as well as my colleagues and funders. And I think I have to stop sharing the screen now. Thank you. Yeah.
Well, Anne-Marie, thank you for a lovely talk. And now Dr. Walsh will join us from Nottingham, UK. Welcome, Dr. Walsh.
Thank you very much. So I'm Dave Walsh, not from UK, and my remit here is to try and extend what Anne-Marie's told you towards information about clinical trials. These are my declarations. So, going to talk a little bit about what we're treating and why. Sensitization and innervation are the two aspects of nerve growth factor that Anne-Marie was pointing out there. It causes sensitization and nerve growth. And I'm going to talk a little bit about patient outcomes to set some of the context for what I think Marc is going to be talking about later, that in terms of what really matters in terms of benefit and adverse events. So just to take you back, what is pain? Sounds like an obvious question. This is the revised International Association for the Study of Pain definition of pain, recently revised this year. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it's important from this to recognize that pain is not tissue damage. It's related to tissue damage, and that also that pain is not purely a sensory experience, it's also an emotional experience. And Anne-Marie talked quite a bit about the links, the connectivity within the brain, which link the sensory and the emotional components of this. That's important when you measure pain. So Anne-Marie showed some animal data in which pain is being measured by behavior. And in fact, all our measurements of pain are behavior, whether it's filling in a questionnaire or whether it's observing an animal. And the two key measurements that she was showing related to weight-bearing asymmetry and sensitivity, so tactile sensitivity. Okay. When we come to people with pain, we measure it in a whole range of different ways. We can measure the severity, we can measure the time course, whether it's intermittent, as Anne-Marie was saying at the beginning, or whether it's constant. We can measure the quality, whether it feels burning or throbbing. We can measure the emotional components, whether it's associated with anxiety or low mood. We can measure impact on quality of life and activities. We can measure psychological mediators, and Anne-Marie mentioned catastrophizing, or we can have measures which are trying to pick out specific mechanisms along that complex pathway that Anne-Marie described. And all these different measures give slightly different things. And in general, those measures which are looking at mechanisms tend to be less relevant to what really matters to patients. And those that really matter to patients often give us, unfortunately, only very slight insight into underlying mechanisms. Pain is very complex. So we have patient global measures and we have disease-specific measures such as the Western Ontario pain measure, the WOMAC. And you'll see clinical trials for OA pain relief typically use those two measures. Okay. We can have unidimensional measures as trying to rate your pain on a single line, or you can have composite measures trying to capture multiple components of the pain. We can use biomarkers, and Anne-Marie talked about quantitative sensory testing as a biomarker of sensitization, a specific pain mechanism. But this isn't a measure of pain, it's a biomarker for a mechanism of pain. We can use brain imaging. And then we have surrogates, which I think one needs to be wary of. Things like analgesic use, joint replacement surgery. Believe me, there are a lot of factors which lead to somebody having or not having joint replacement surgery, and it's not just pain that drives that. There's questions of availability, which differs around the world. There's fear about what possible side effects and complications might be. There's anecdotal experience from the other knee or from relatives and so on. So actually these surrogates are not necessarily good measures of pain. So I've given that brief overview really just to get you thinking about what is pain and what we're trying to measure. And I think when you think about it like that, it would be unrealistic to expect a magic bullet to get rid of pain completely. That doesn't mean to say, however, that there aren't treatments which can make a major impact. And I think this is where we've been going with some of the recent developments. So I won't linger on that slide because Anne-Marie's already shown that complex pathway. Nerve growth factor. Nerve growth factor augments pain. And Anne-Marie showed evidence from an animal model. People have injected nerve growth factor into human muscles and it augments pain. But it doesn't cause pain. It increases sensitization. And it does that by phosphorylating ion channels, reducing their activation threshold. It alters gene expression in the primary afferent neuron in the nociceptive pathway. It increases transmission, things like glutamate, and it increases release of neurotrophic factors and factors such as brain-derived neurotrophic factor, which then sensitize the second-order neurons and beyond. And it's possible to interfere with that pathway, with the NGF pathway, through a number of techniques. And Nancy showed in the corner of one of her slides sort of a brief overview of this. There are a number of antibodies which are blocking antibodies which bind to nerve growth factor in the peripheral tissue. So antibodies are big, they typically don't get into the central nervous system. These are peripheral effects. Some of these are still being developed. Some of these are pure NGF blockers. Some of them seem to have blocking activity for inflammatory cytokines, such as tumor necrosis factor. Some of them are still being developed. Some have been developed part way, and they've fallen on the wayside for various reasons. It's possible to block the actions of nerve growth factor on its main receptor, the TrkA receptor. And that's been quite challenging. These TrkA receptors are difficult to produce competitive antagonists for, but there are allosteric inhibitors out there which have been developed, which also block the nerve growth factor pathway. And so those are continuing to be developed in for clinical use. None of these are in clinical use at the moment. So this is all future stuff. You can't go to your doctor and ask for something to block nerve growth factor. Reassuringly, preclinical and clinical studies using antibodies to nerve growth factor, other blockers of nerve growth factor, and inhibitors of TrkA all seem to be giving fairly consistent results in terms of efficacy. It's pretty convincing that nerve growth factor is important in osteoarthritis pain, both in animal models and in humans. Anti-nerve growth factor isn't analgesic. And you don't want something to block all pain. Pain is a protective response. If I'm cooking and I touch a hot plate, I want to remove my finger from it. I want to know it's painful. And if you have something which blocks all pain, we're going to have a lot of problems. There are people with genetic deficiencies who cannot experience pain, and they end up with a lot of clinical problems. Okay, it might sound nice to somebody who's got a lot of pain at the moment, but it's not nice in the long term. So what you really want to do is to block pathological pain. And that's where going for the nerve growth factor pathway has huge potential, because blocking nerve growth factor will not block, as you can see in the lower panels in this, thermal sensitivity, mechanical sensitivity in a normal situation, but it will reduce responses in a pathological situation. So nerve growth factor works by reducing sensitization, but it also does block nerve growth, as Anne-Marie was showing to some extent. This applies both in animal models and in human models. And this is some data from synovium. We've shown that if you take synovium from people with osteoarthritis of the knee, two groups of people here, the cartilage looks the same in both groups. But one of the groups has gone for a joint replacement surgery because of severe pain, and the other group hasn't. They're actually post-mortem controls. And the symptomatic group has higher expression of nerve growth factor than the asymptomatic group. That's synovium. This also applies in those osteochondral channels that Anne-Marie was pointing out. And again, this is in human. So there's increased nerve growth factor expression, or there's an increased proportion of those channels containing nerve growth factor in people with pain and osteoarthritis, opposed to less painful osteoarthritis. And that increase in nerve growth factor is associated with an increase in innervation. So again, this is in humans. People with symptomatic chondropathy have higher proportion of these osteochondral channels containing sensory nerves than people with asymptomatic chondropathy. And similarly in animals, we've been able to do interventional studies. So this is one of those TrkA inhibitors, which shows that if you treat an animal for a month or so while it's developing osteoarthritis, then it doesn't develop this increased innervation of the osteochondral junction. And I've focused on synovitis, on the synovium and the osteochondral junction, because in humans, those seem to be the regions where pathological change, for example, as demonstrated in MRI scans, is associated with pain. There are other aspects of osteoarthritis which seem to be much less associated with pain and probably don't contribute to it. Some of those aspects, osteophyte formation may be really a repair response and not be the cause of pain. This is important to recognize if you're trying to develop disease-modifying drugs. Trying to develop a disease-modifying drug, you only want to modify the bits of the structural disease which are actually causing patients problems. And the osteochondral innervation is associated with pain behavior in the animal models. Which of those is important? Is it nerve growth or is it sensitization? Well, the time course of the major analgesic effect of nerve growth factor inhibition suggests that it's a blocking of sensitization. This is much too quick to be blocking that nerve growth. Okay, that doesn't mean to say there aren't additional benefits from longer term treatments, but of course there might be additional disadvantages of longer term treatment as well. I talked about consistency between the animal data and the human data. There's also remarkable consistency between studies of NGF blocking antibodies. And these are pre-2015 randomized controlled trials of Tanezumab, which is the most advanced in terms of clinical development of the nerve growth factor blocking antibodies. This is in osteoarthritis pain And you can see remarkable consistency across multiple studies in terms of benefit in favor of Tanezumab. And Tanezumab's not the only blocking antibody. Similar consistency has been found with the other nerve growth factor antibodies such as Felranimab and Fasinumab. The TrkA inhibitors have been more difficult to develop. There are some data for locally injected TrkA inhibitor suggesting it may have analgesic benefit. This is a very early type of study in human. But there are also data with other TrkA inhibitors which have failed to reach their primary endpoint. So in terms of progress towards clinical practice, the blocking antibodies are much more advanced than TrkA inhibitors. Do we want to relieve pain? I talked earlier about the distinction between blocking pathological pain and blocking all pain. And I think we all have this idea that wouldn't it be nice to block the underlying disease, block the structural change? Do we really just want to block pain? Well, my patients say, yes, we do, because that's really the problem that they've got. They're not really asking me to block osteophyte formation. They're asking me to make their knee less painful so that they can carry on doing the things that they want to do. But if you block pain, are people going to overuse their joint? And when nerve growth factor antibodies were put into clinical trials, it was found that there were some significant side effects being picked up. And again, these unfortunately seem to be consistent across the nerve growth factor antibodies. It's not just one study that's shown this. What's that due to? Well, we don't know. But this assumption that it's because people are using a joint when they shouldn't, I think we need to be very cautious about. And I think David Felson actually might be involved with some of this work on runners as well. And really, there is very little evidence that using osteoarthritic joints makes them deteriorate. Now, that clearly is not the case if somebody's got a fracture, and it's not going to be the case in all situations. And I think the jury's out in exactly when we do not want to relieve pain. But suggest that we don't want to develop analgesic agents for osteoarthritis because we don't want people to use their joints is a complete anathema to me as a clinician. And I believe that it's an anathema to most of my patients as well. So we've got to think about this. There are other ways of blocking pain from joints. And I'm just sort of throwing this one in. Cryoneurolysis, of course, will block pain from the joints. It reduces the afferent transmission of pain signals from the joint, and it can relieve pain. And it's really important that we understand why nerve growth factor antibodies are associated with some specific side effects, because actually if it were because people were overusing the joint, then we should stop developing all these other treatments as well. I don't believe that to be the case. The other thing about side effects from treatments is how important are they? And we all have our different perspectives. A radiologist has a different perspective to a rheumatologist. And a rheumatologist will often have a different perspective to the FDA. And the FDA may have a different perspective to the patient. And we need to be listening to each other. For me, the key person at the center of all this is patients. What matters to patients? How important is it if some people on a treatment develop rapidly progressive osteoarthritis? And this is a study we did trying to address this and comparing it with other side effects of other analgesic agents, opiates, non-steroidal anti-inflammatory drugs. And it's not to say that these side effects are not important, because they certainly are. But actually, the most important thing for patients that came out from this study is pain relief. People are willing to risk side effects if they're really going to get benefit. It's up to us to explain pros and cons of treatments. It's up to us when we're developing new treatments to minimize the risks and to maximize the benefits. It's not up to me as a clinician to tell somebody that they can't have something which is going to benefit them. So I tried to take forward your thoughts about what we're treating and why we're doing it. Sensitization and innovation are the targets for nerve growth factor, particularly sensitization. And I've addressed patient outcomes and hopefully got you thinking a bit about what really matters here. Thank you very much.
Thank you very much, David. That was very, very complete and useful information as we go forward in thinking about how to treat the pain of osteoarthritis and where we are today. And now I would like to share my screen and see if I can talk a little bit about the studies that have been done with the anti-NGF compounds and a little bit about what's been done with the TrkA inhibitors. Can everyone hear me? Okay. So I am grateful for Dr. Malfait and Dr. Walsh, who've given such a wonderful overview of how pain occurs in osteoarthritis, and then how the translation of the biology into pain and new therapies. And now I think I have the easier job to discuss a few of the studies that have been done with the inhibition of nerve growth factor. Now, as been shown in our previous speakers, nerve growth factor is released from injury, from around the joint, for sure in the synovium and the bone. And what it does is it goes to its TrkA receptor on the nociceptor and then moves to the dorsal root ganglion, where it then sets off a number of signals that go into the central nervous system, and the patient reacts with pain. There is another receptor for the nerve growth factor on a mast cell, which can result in some release of histamines and sometimes some peripheral edema and swelling, but that's not particularly something we see much of in the osteoarthritic field. The interesting thing about nerve growth factor, as its name applies, is it both sensitizes us to, tells us there's pain, and also stimulates the growth of new pain receptors, which makes it a very interesting compound. A number of years ago, actually surprisingly, well over 20 plus years ago, an antibody to nerve growth factor was made and tested in a number of different disease states. However, about 15 or 16 years ago, the antibody to nerve growth factor was studied in patients with painful knee OA. And the initial phase 1 studies, which I won't show you any slides about today, showed us one thing that we'd never observed before. One injection of the antibody to nerve growth factor, in this case Tanezumab, resulted in about a 6 to 8 week reduction in pain in the patients with painful knee OA. And that led to a phase 2 study, which was to look at not just the safety and the efficacy of the nerve growth factor antibody Tanezumab. I participated in that study, and I'm showing you here a picture of the patient or subject characteristics that joined that study. Most of the patients were about 60 years of age, more females than males. But when we looked at a Kellgren and Lawrence score, which reveals the severity of the radiographic disease, you can see many of the patients had moderate to severe radiographic osteoarthritis. And walking pain, which goes on a scale of 0 to 100, was at 70. So these patients were quite diseased, if you will, suffering from pain and structural deterioration from osteoarthritis. And what we found in these first studies with Tanezumab, and the medication was given intravenously. I want you just to appreciate that, because later studies I will show you the medication is given via subcutaneously through the skin. We really saw within a week that compared to placebo, the Tanezumab treated subjects had a reduction in pain, especially when walking. And they were given an injection again at 8 weeks, but you can see the duration of the reduction in pain lasted up to 8 weeks. Another injection was given, and they also maintained that reduction in pain compared to the placebo over another 8 weeks. In my career as a rheumatologist treating patients with osteoarthritis of the knee, I had never seen an agent that had that long of a duration of effect. And not just did you see a reduction in pain compared to the placebo, it was about doubling, but they'll function. The patients were functioning better and had less stiffness. And that also was maintained out to 8 weeks. Now, this is an old study, coming 10 years old, but we were just beginning to use the ORSI-OMERAC responder index, and it was nice to use it in this study so we could then see, compared to placebo, that there was an increase in the responder index in the higher doses of Tanezumab over 80%. Again, nothing that I had experienced to that point in studying osteoarthritis of the knee. Now, in any study in the development process, you all know that safety is a major concern, and we followed these patients and obtained safety assessments. We did see something early on in these studies, in that there was a subgroup of patients that developed paresthesia. And for the most part, it went away, but it was up to about 11% in this particular study. Now, a number of these patients had derived benefit from Tanezumab, and they were asked if they wanted to continue the therapy to obtain more safety. And so one dose of the medication was decided upon, and the patients continued, a number of them continued and obtained up to 8 doses of the Tanezumab. And for the most part, they still maintain that reduction in pain with each injection, or at this time it was an infusion, suggesting that there was some real durability in the effect. So that was the phase 2 study. And now I'm showing you a picture or a slide of a summation of a number of the phase 3 studies that were done with Tanezumab. And I want to mention that these studies were done again with intravenous injection of the medication. They were a little bit different in that some of the studies used the non-steroidal naproxen as a comparator, and some of the studies use celecoxib, the COX-2 inhibitor, as a comparator. There were a number of groups, Tanezumab alone or Tanezumab in addition to with a non-steroidal drug. But you can see that compared to the non-steroidal drug naproxen, Tanezumab was effective in reducing pain and improving function. And it seemed to increase with both the dose of Tanezumab and also with the non-steroidal drug. Please note that the patients in these studies both had osteoarthritis of the knee and osteoarthritis of the hip. However, as those phase 3 studies were being done, and Dr. Hochberg will speak more about today, there was a group of patients, a subgroup of patients in the different treatment groups that actually developed a rapidly progressive form of osteoarthritis, both at the hip and knee. And it appeared to be more frequent with higher doses of the Tanezumab and when they were also treated with the nonsteroidal. Many of those patients that developed the rapidly progressive osteoarthritis also had joint replacements. And again, it was a similar groups with high doses of Tanezumab and with the NSAID, and it appeared to occur pretty much between about 112 and 168 days in the studies you saw the change. Okay. So there was a break in the development of the Tanezumab and other anti-NGF antibodies for the treatment of painful osteoarthritis. Dr. Hochberg will speak more to that issue and how it was resolved. However, after a break of a few years and a lot of work being done by a number of people in the field and in pharmaceutical companies, the FDA agreed to start the program again. But what I want to, it was changed in the sense that Tanezumab was then given first subcutaneously, not intravenously, and at doses of 2.5 milligrams or 5. The injections were still about 8 weeks apart in patients with moderate to severe osteoarthritis. Now I'm showing you here one of the study designs for one of the pivotal trials that was done and published by Tom Snitzer and others. A year or two ago, patients with painful osteoarthritis were randomized to placebo, Tanezumab 2.5 milligrams, or 2.5 milligrams, and at 8 weeks, they could be titrated up to 5 milligrams if needed. And then they were followed another 24 weeks to make it about a 6-month study. Looking at the endpoints here, if you use my gray bar as placebo treatment, you can see that both 2.5 milligrams of Tanezumab or 2.5 titrating up to 5 appeared to reduce pain more, the WOMAC pain scale, compared to placebo, and also physical function was improved. And if you looked at the WOMAC pain responder index, you can see that if you look at whether 30% or 50% or even 70%, you can see that the either 2.5 or 2.5 titrating up to 5 milligrams of Tanezumab were significantly different, and more improvement was seen with those treatments than placebo. However, you can see that there were some adverse events, there were some joint replacements, and they were a little bit greater if you looked at a little bit more if you looked at the 2.5 milligram titrating up to 5 than placebo. Although there weren't very many, there were some. So that led to a large study, which Dr. Hochberg will speak more to, looking at safety endpoints. And this study is a little bit different because there was a non-steroidal treated group, a Tanezumab treated group at 2.5, and a Tanezumab treated group at 5 milligrams. As you can see, the number of study subjects was nearly 1,000 study subjects per each group. It's a very large study. And Dr. Hochberg will speak to those results of that study after me. I do want to mention that Tanezumab is not the only anti-NGF therapy that is being studied right now. And Felson by Regeneron Pharmaceuticals with Teva has also an active development program going on. I'm showing you here the results of a phase 2B, phase 3 double-blind, placebo-controlled randomized clinical trial, where again, you can see compared to the placebo group that all doses of the fasinumab were significantly different in terms of reducing pain, and the pain reduction also lasted quite a while. However, similar to tanezumab, as you got into higher doses of the fasinumab, you began to see an increase in the number of adverse events that required joint replacements, including the subchondral insufficiency fractures and rapidly progressive OA. So in the development program for fasinumab also is modified to one dose, I believe, being given either at 1 month or 2 months. So based on adverse events at higher doses, there was a modification to the plan. Now, since the NGF signals through the TrkA receptor, it would seem reasonable to look at inhibition of the TrkA receptor. We say TrkA, but it's really tropomyosin-related kinase A receptor for the nociceptor, and see if that would be a more direct way to reduce pain and maybe without adverse events. And there had been a few TrkA receptor inhibitors that were studied in phase 1. However, only one, to my knowledge, has been given systemically. And that was one study that was published recently. Fiona Watt and I were authors on that from Estella Pharmaceuticals. The preclinical animal studies showed significant efficacy with this TrkA inhibitor compared to placebo in pain and function. So appropriate doses were chosen for a phase 1 study. There was no toxicity associated with the medication, so a phase 2 study was done in patients with painful knee OA, and I show you here the WOMAC subscale for pain. You can see placebo, and then you can see the TrkA inhibitor, and you see naproxen. The TrkA inhibitor was not as effective as naproxen, and by all endpoints did not separate from the placebo. The etiology for that is not quite clear, but so far no TrkA receptor inhibitors are in development for osteoarthritis. So I'm going to conclude my session on therapy by really saying that these anti-NGF compounds appear to reduce joint pain and improve function compared to placebo or nonsteroidal drugs. What is unique about them is that they work with, efficacy appears within a few days and is maintained out to 8 weeks in most patients. Repeated NGF injections after 8 weeks appear to have similar efficacy in reducing the joint pain as the initial injection. And it does represent a novel pathway for analgesia for individuals with painful knee and hip OA that provides prolonged analgesia. And I'll stop now and introduce Dr. Marc Hochberg, who has many titles and quite accomplished, in maybe the most accomplished person in the field of osteoarthritis and clinical therapies, because he's been instrumental in actually studying the adverse events of the anti-NGF compounds and can really speak to us on their safety. Welcome, Marc.
Thank you very much, Nancy. Very kind of you with the introduction. So let's see, is my screen shared?
Well, you are, not yet your screen.
Okay, I think we have the screen shared now. Is that correct?
Yes.
Okay, so to quote David from earlier on, my remit here was to talk about the safety of the anti-nerve growth factor antibodies. And let's see how we move forward here. if we can. There we go. So here's my disclosures. As several of the panelists spoke about earlier, with regard to the development programs of the antibodies to nerve growth factor for treatment of chronic pain of osteoarthritis, as well as chronic low back pain and other chronic painful conditions. Originally, there were 3 inhibitors that were under development. There was Tanezumab, which started out with Pfizer Incorporated and is now Pfizer and Eli Lilly. Fasinumab, which started out with Regeneron and is now Regeneron and Teva, and Fulranumab, which started out with Janssen, but is no longer in clinical development. As was mentioned by Nancy, there were holds that were put on the class of drugs by the Food and Drug Administration for development. After the parenteral development program for Tanezumab and the early development program of Fulranumab, there was a hold that was put on in 2010 for reports of serious joint-related adverse events, which were considered by the investigators in the field to be osteonecrosis based on both findings from conventional radiographs as well as CT scans. And this led to a review of the adverse events and an FDA Arthritis Advisory Committee meeting, which was held in the spring of 2012. After the data were presented from the sponsors at that committee meeting, the Food and Drug Administration released the clinical hold during the summer of 2012. But then in December of 2012, a second hold was put on because of findings of sympathetic nerve system toxicity in preclinical models. Now, during this time, there were several systematic reviews published, both of the efficacy of the anti-NGF antibodies, as well as the overall safety. So let me briefly review those. You've already seen some data from the systematic review published by Tom Schnitzer and Marks in 2015, which looked at the efficacy of the anti-NGF compounds for pain, physical function, and patient global assessment. I think Prof. Walsh showed these, both for Tanezumab as well as for Fasinumab and Fulranumab. And this was also in a focused review by Kahn and colleagues, just looking at the Tanezumab trials. So all of these compounds were shown to be efficacious for these 3 outcomes. Now, the overall incidence of adverse events was found to be higher in the patients who were treated with anti-nerve growth factor antibodies than those who received placebo. And the most recent review of those data was published just this year by Yang and colleagues, and I'll show you some data from that paper in a few slides. The 2 areas of concern with regard to adverse events were the neurological and the musculoskeletal. Neurologic adverse events, including paresthesia, hyposthesia, mononeuropathy, and peripheral edema, which may be mediated by sympathetic nervous system, was found to be in about 5 to 10% of patients, and as we'll see, led to an increase in withdrawals due to adverse events. And then the serious joint-related adverse events, which turned out to be something called rapidly progressive osteoarthritis, a recognized subset of osteoarthritis, primarily in the orthopedic literature, and not osteonecrosis, as it was first labeled by the investigators, was reported with higher doses of anti-NGF antibodies, and also when the anti-NGF antibodies were given in combination with oral NSAIDs. And this was what led to the clinical hold, and this was what was determined after those data were reviewed. So this is the data from the recent paper by Yang and colleagues in Frontiers in Pharmacology, which was published online about 2.5 months ago, showing differences in the adverse event rates in the randomized controlled trials of Tanezumab for both osteoarthritis and chronic low back pain. And this looks at all doses combined, and you can see that the majority of the studies show a risk difference in favor of placebo with an increase in the rate of adverse events with Tanezumab. And overall, there's about an 11% increase in the rate of adverse events with Tanezumab as compared to placebo, and this is statistically significantly different from zero. There is heterogeneity across the trials, and I should mention that the one that's illustrated on top, Kivitz 2013, is in chronic low back pain, while the others are in osteoarthritis. So there's a higher incidence of adverse events overall. And what about withdrawals due to adverse events? So this comes from the meta-analysis by Schnitzer and Marks. And this is, again, of the Tanezumab trials. And these are data across 10 trials. And they show that there's an increase in the rate of withdrawals due to adverse events of about 50%, an odds ratio of 1.5, which is significantly different from 1. Here, there's no important heterogeneity across the trials. Now, what about the types of adverse events? Well, this slide is a bit complicated, and I don't want you to look at the individual lines within the subplots. But this is a series of 4 forest plots taken from the review by Can and colleagues. So on top are the discontinuations due to adverse events. Again, a relative rate of 2.9 for active compound compared to placebo. Serious adverse events is the second group, and here it's not statistically significant compared with active NGF inhibitor compared to placebo. If you get to those discontinuations due to abnormal peripheral sensation, which is in the third group, you can see that the relative rate here is about 3. So a 3-fold increase in the risk of discontinuing drug because of abnormal sensation. And then for frank peripheral neuropathy, diagnosed by a consulting neurologist, there's a 6-fold increase in the risk of discontinuation. So these neuropathic adverse events associated with NGF inhibition do lead to an increase in the risk of discontinuation. Okay. Now, what about the safety of Tanezumab in pooled analysis? So this paper published in 2019 by Leslie Tive and colleagues gives you an integrated safety summary based on almost 8,000 participants in phase 3 clinical trials of Tanezumab for hip or knee osteoarthritis. And about 1/3 of these individuals were age 65 and above when they entered the trial. So I've already shown you that Tanezumab was associated with an increased risk of adverse events overall, withdrawals due to adverse events, and in this analysis, also serious adverse events compared with placebo. If we look at the neuropathic adverse events, there was a higher rate of adverse events for abnormal peripheral sensation, both paresthesias and hypoesthesias, as well as a development of a diagnosis including peripheral neuropathy or carpal tunnel syndrome. But there was no increase in the risk of adverse events suggestive of sympathetic nervous system dysfunction, which was one of the reasons for a partial clinical hold due to findings in preclinical models. Now, Dr. Lane showed you the efficacy data from the study of Felson in hip or knee osteoarthritis, published last year in Arthritis and Rheumatology. The safety data in that publication showed an increase in the risk of adverse events, 62 versus 55%, withdrawals due to adverse events, 4 versus 1%, but no difference in serious adverse events, which were rare in this study. Felson was associated with a higher rate of adverse events of abnormal peripheral sensation, including both paresthesia and hyposthesia, but only one subject developed carpal tunnel syndrome, and there was no increase in the rate of adverse events suggestive of sympathetic dysfunction. She showed you the data that rapidly progressive osteoarthritis occurred in 16 Felson versus no placebo-treated patients, and a dose-response relationship was noted with Felson as it had previously been noted with Tanezumab. So let me bring you up to date then on the current status. As was mentioned, Felranimab development was discontinued in 2016 based on strategic portfolio prioritization by Janssen. Felson is currently in phase 3 for osteoarthritis. The higher dose was discontinued for safety concerns, and top-line efficacy results for the lower doses have been released in the media, showing efficacy for the 1 milligram dose either monthly or every 8 weeks. Tanezumab has completed the phase 3 for osteoarthritis, and an FDA submission is pending. Dr. Lane showed you the results from study 1, and a second study of 24 weeks in duration was published by Francis Berenboom and colleagues in the Annals of the Rheumatic Diseases. So I'll finish up with some of the data from the long-term safety study. The protocol diagram shown here, the phase 3 randomized double-blind, double-dummy, NSAID-controlled parallel group study, where about 1,000 patients with symptomatic hip or knee osteoarthritis were randomized to continue either NSAID therapy, receive Tanezumab 2.5 milligrams subcutaneously at baseline in week 8, and then if they had at least 30% improvement in pain, continue it for additional injections at weeks 16, 24, 32, 40, and 48, or Tanezumab 5 milligrams given on the same dose schedule. The key inclusion and exclusion criteria are shown here. You should know that this study involved a risk mitigation strategy so that individuals with radiographic evidence of pre-specified joint safety conditions at screening, such as subchondral insufficiency fractures, were excluded from the study. The primary endpoint in the study was a composite joint safety endpoint, which included rapidly progressive osteoarthritis type 1, defined as a significant loss of joint space of greater than or equal to 2 millimeters, predicated on optimal joint positioning within approximately 1 year. This is digitized films, which were read using the digitized images by computer reading, or rapidly progressive osteoarthritis type 2, which requires abnormal bone loss or destruction, including limited or total collapse of at least one subchondral, usually weight-bearing surface, or the development of primary osteonecrosis, a subchondral insufficiency, or a pathologic fracture. These individual endpoints were included as secondary endpoints as well as total joint replacement. So this shows the results for the primary composite joint safety endpoint. These data were presented at the annual meeting of the American College of Rheumatology last year. And you can see a dose-response relationship, so that in the NSAID comparator group, about 1.5% of individuals developed this adverse event at a rate of 15 per 1,000 patient years. The Tanezumab 2.5 milligram group, again, about 4% at a rate of 38. And in the Tanezumab 5 milligram group, 71 individuals at a rate of 71 per 1,000 patient years of follow-up. And both Tanezumab groups were statistically significantly different from the NSAID comparator. If you look at the individual joint safety endpoints on your left, you can see rapidly progressive osteoarthritis type 1, which is the loss of joint space or joint space narrowing at a greater rate than would be expected. And you can see that that occurs in a dose-dependent fashion. In the second set of bars is rapidly progressive osteoarthritis type 2. And you can see that the low-dose Tanezumab is similar to the NSAID comparator, but an increase in the high-dose Tanezumab group. Primary osteonecrosis was rare, occurring in only 2 individuals, and subchondral insufficiency fractures were uncommon with no statistical separation. Total joint replacements occurred more commonly in the Tanezumab treated group than in the NSAID comparator, again in a dose-response relationship. And these were largely due to symptomatic osteoarthritis and not due to either rapidly progressive osteoarthritis type 1 or rapidly progressive osteoarthritis type 2, except in the high-dose Tanezumab group, where about 1/4 of all the total joint replacements were due to a primary composite joint safety endpoint. So in conclusion, monoclonal antibodies to nerve growth factor are associated with an increased risk of adverse events compared with placebo, and also in the long-term Tanezumab joint safety study with NSAIDs. These adverse events primarily are neurologic, including hypoesthesia as well as paresthesia, and joint-related, what's called rapidly progressive osteoarthritis. And now the term for rapidly progressive OA type 2 is rapidly destructive osteoarthritis, submitted to the Centers for Disease Control for inclusion in the next revision of ICD-10, and an increase in total joint replacements. These adverse events appear to be dose-related. So with Tanezumab, the lower dose has a more favorable joint safety profile than the higher dose. As I showed you, the incidence of the primary composite joint safety endpoint and RPOA type 1 were significantly higher with Tanezumab 2.5 than with NSAIDs, as well as the incidence of total joint replacements being significantly higher. So I want to thank you for your time and attention. And I think this leaves adequate time for panel discussion and Q&A. And hopefully my screen will be taken over now by the Arthritis Foundation.
Thank you, Marc, for that thorough review of what I'll say, the safety and the development of the anti-NGF compounds. And while we await the FDA's decision, hopefully by the end of the year, on whether to approve the use of Tanezumab for the treatment of painful osteoarthritis. Now, I would like to have a panel discussion, and I have a patient, Cindy, who has a question. And so Cindy, can you ask your question, please?
Yes. Can you hear me?
Very well, yes.
Okay, great. Actually, Dr. Marc just answered pretty much one of my first questions, was to know what worsened in the joint. what caused the joint to have more, of the rapid progressing osteoarthritis. And if I understood correctly, it was dose related. So the dose was adjusted to stop those side effects. Is that correct?
Well, you're correct in that it's dose related, and it's seen with the higher doses of both Tanezumab and Felson. And in the earlier development program with Tanezumab, it was seen when the drug was given in combination with non-steroidal anti-inflammatory drugs, such as naproxen and celecoxib. So that was not allowed in the recent phase 3 development for the subcutaneous compound. So what causes this? I think there's speculation now as to what causes it. Is it related to, so it's not due to an analgesic effect, as David showed earlier on, that you're not obliterating pain to the extent that an individual will have greater physical activity, overload the joint, and cause joint destruction. So that does not appear to be the mechanism. The mechanism possibly is related to actual inhibition of NGF on the osteoblast, or the bone-forming cell within the subchondral bone. It also may be related to effects of NGF inhibition on those nerves and the blood vessels that come through those osteochondral channels into the articular cartilage from the subchondral bone, leading to decreased nutrition of the articular cartilage and the subchondral bone itself. And the type 1 appears to be related to changes in the meniscus with what's called extrusion of the meniscus, so that there's narrowing of the joint space on a weight-bearing X-ray. And whether that's related to those NGF expressing fibers within the meniscus or not is unknown at this time. I'm happy to have Anne-Marie or David comment on what they think might be involved in terms of mechanism of action beyond that.
Thank you.
Yeah, do you want me to come in sort of briefly on that? So I think, Mark, that reflects my biases as well. But I think the short answer is we don't know. So although I agree with Mark, I think it's pretty clear this isn't because of pain, of osteoarthritis pain relief. It's not clear to me whether there might be something else that's happening to these people. We've got to remember this is a rare side effect. The vast majority of people do not experience this side effect. And it's possible that something else is happening, which the analgesic effect for that is then leading to rapidly progressive osteoarthritis. So there are unanswered questions with that, I think. But the bottom line is that it is a real side effect with the nerve growth factor blocking antibodies. And it's important to minimize the risk of those side effects if people are to really get benefit from them.
Thank you.
Could I please, thank you, David and Mark. I wanted to add something, and I see that Dr. Felson also put in the chat box if NGF inhibition should cause only sensitization and not analgesia, and if pain protects joints from damage, why do these agents cause joint damage so often? And I just wanted to add to the answer that I do think that we also have to stress that the receptor for NGF is not just expressed by neurons, by sensory neurons, but by many different cells in the joint, and that we actually at this point do not have a very good view on which cells, when and where exactly express that. So there may be other direct effects on joint tissue cells. And the same is arguably true for NGF itself. We do not know exactly when it gets produced, where it gets produced, and then, you know, what it binds to, and then what the relative role is of the other receptor. So I think there are a lot of unanswered questions that that are playing here that may actually take it away from analgesic or hyperalgesic effects and from the pain and from the nervous system itself.
I just add as well that
That's a good point. Go ahead. I'm sorry, who's speaking?
yeah, so it's me again, I'm afraid. So it's Dave Walsh. So Mark and Nancy referred to risk mitigation strategies, and I think it's important to recognize that there are ways of reducing the risk. So one was to warn people against using non-steroidals because that does seem to have increased the risk of joint damage from these things. And it's not that people taking non-steroidals got any better pain relief, because they didn't. So there's no point in taking non-steroidals alongside the anti-NGF. But also, these are painkillers. It's not something that's designed to stop a one-off event like a death. People can use the painkiller. If it doesn't work for them, they can stop it. So one of the problems we have in clinical practice with painkillers, and this applies to opioids and to other painkillers, is that people start on them and yet they don't critically work out whether they're really helping them. And they just keep taking them because they're being prescribed. And we need to get away from that so that we've got to recognize there are differences between individuals. The vast majority of people will not get rapidly progressive osteoarthritis, but some people will. You know, a large proportion of people may get pain relief, but some people won't. And we need to make sure that people who are not getting the benefits are not exposing themselves to the risks from any of our analgesic agents.
Okay, Dan Clauw asked a question to everyone, and it's an important question in terms of treating our patients or thinking about mechanism. Commenting on the relative effectiveness of NGF antibodies versus NSAIDs, because the very recent trials now, we have lower doses of the NGF antibodies, very large sample sizes, as you can see in the last study that Marc Hochberg showed us. There were 1,000 people per arm. And if you compared NSAIDs to the NGF antibodies, you saw significant differences, but again, would these be clinically meaningful? The IV doses were higher. So Marc, do you want to comment on that, or David comment on that?
Well, I'll be happy to comment, and David can comment as well. So I think you would use these compounds at different points in the journey of a patient with symptomatic osteoarthritis, and of the knee or hip, okay? In that, you know, as was pointed out, people start off their journey with intermittent pain, which comes and goes, for which they may self-medicate with over-the-counter analgesics. And then when the symptoms become persistent, they will then, if over-the-counter analgesics are not suitable, go and seek out treatment. And this may involve topical agents for the knee or oral agents for the knee or hip. And largely this will involve non-steroidal anti-inflammatory drugs unless there are relative or absolute medical contraindications. It would not, I think, involve subcutaneous injection of an anti-NGF compound. Okay? Where the anti-NGF compound would fall in the journey is later on in the journey. After a patient has not had adequate relief of their persistent chronic pain or has not tolerated an NSAID, maybe has not had adequate relief or has not tolerated intra-articular therapies, doesn't want to use opioid analgesics, maybe is not a candidate yet for surgery, or if they are a candidate for surgery, may have comorbidities which make the surgeon reluctant to proceed, or the anesthesiologist reluctant to proceed, or they may be unwilling to undergo surgery. So I think it's later on in the journey that we would think about using an anti-NGF compound, and if its amount of efficacy is similar to that of an NSAID, as was seen in this long-term safety study for the 2.5 milligram dose, that's still greater than what you see with placebo injection. So that would be my response to Dan's comment. It's a long response.
And I want to mention that what makes these compounds unique at this point in my mind is that there's a very long duration of therapy, of efficacy. We haven't had something that you could get a treatment of and then maybe for 6 weeks have a significant reduction in pain. That may end up being quite, help our patients quite a bit. And so rather than taking an NSAID once a day or every other day, it could be that this type of medication will allow just less needs for escape therapy. So we'll see. I mean, that's a unique aspect of it, and we'll see if that pans out. That's more how I see it.
I think David wants to comment as well on this.
Please, Dave.
Yeah, I mean, it's a really critical and good question, Dan. My simplistic answer would be, of course, people are going to use non-steroidals first in preference. They're cheaper. They're going to be a lot cheaper. And it would bankrupt health systems to put everybody on anti-nerve growth factor as a first-line treatment. I don't think anybody's proposing that. But I think one needs to be careful about applying minimally clinical reports of differences to mean data. As I was saying, and as you well know, Dan, pain isn't a single thing, and osteoarthritis pain isn't a single thing. And I've got no reason to think that nerve growth factor is just another non-steroidal anti-inflammatory drug. And just because the average effects may be similar between the two, it doesn't mean to say that some people will be responding to one and some people will be responding to another. And the other thing is the side effects. Some people cannot have non-steroidals because of risk of side effects or actual side effects. And the side effect profile is very different. Some people cannot have anti-nerve growth factor because of the risk of side effects. If you've got a subchondral insufficiency fracture to start off with, I would not give somebody an anti-nerve growth factor antibody. But everybody's different, and it's a question of where it fits in that portfolio rather than is it going to replace. I do not believe that nerve growth factor antibodies will replace non-steroidals.
Oh, no, they won't, but it'll be an option. Okay, thank you so much.
Can I just respond to those?
Yes, please, please.
So I agree with everything that's been said, but I do think it's important that we sort of control the narrative here about the relative effectiveness of this class of drugs versus other classes of drugs or other therapies. And I think there has been a tendency for people to say that they work better than NSAIDs, and I'm not positive at the dose they're being given that that's true. I think they might have a slightly larger effect size than NSAIDs, but I'm not sure that I agree that they work, on average better than NSAIDs. I totally agree with what you said, David. Mean pain relief is not important to a patient. Either they got pain relief or they didn't. But this will be important when these drugs get out and get marketed is what sort of the narrative is about their effect size. And I'm sorry, but their effect size is, other than arthroplasty has a great effect size in most people, but this will be about like everything else is that we use for pain, is it will work in some people, but not a lot of people.
Just to quickly come back on that, if you look back at the responder analysis that Nancy was saying, for some people that's not true. I think it is true for the mean effect size, and I think you're quite right, Dan, that we mustn't overblow these things. One of the things that I think is damaging in medicine is raising expectations beyond what can be delivered, and it's important that we don't do that with any new treatment, I think.
Sure, we are in a data-free zone until we see if these medications get approved and how best to use them in our practices. All points made are extremely important. And I thank you, Dan, for bringing up some of the issues related to the newer studies and the comparative efficacy of the two types of treatments. Let's move for a minute now to a question from a patient. The question is this is from Emily Hunt to everyone. I'll read it, Emily, and hope that I don't butcher it too much. I have knee or hip pain.
One second. I'm so sorry, Nancy. This was not from me. This is from a patient who sends it privately in the chat. So if that patient wants to, or I think it's Dr. Liu actually wants to unmute themselves and ask the question directly.
Oh, perfect. Thank you. That makes it so much easier for me. Go ahead.
Okay, the chat's not really working for me because I can't chat with everyone. But my question is sort of in the same vein as what's already been asked before, but a little different. Is the reason that we aren't seeing adjudicated cases of osteonecrosis events in the more recent trials due to the risk mitigation strategies, or could it be because the cases of ON seen in the earlier trials were likely unrelated, or could it be due to other reasons?
Okay, anyone in the panel would like to answer?
Sure, I'll take a crack. So the cases in the earlier trials were actually not really osteonecrosis. What they were is what was considered by the adjudication committee to be rapidly progressive osteoarthritis. And it was not well reported in the rheumatology literature, but it was actually well reported in the orthopedic literature, particularly affecting the hip joint in older individuals, more often women than men, more often with a form of osteoarthritis that it used to be called atrophic osteoarthritis, where there was osteopenia of the femoral head and not a lot or any osteophyte formation. And also it occurred in the knee joint where there was collapse oftentimes of the tibial plateau, but sometimes of the femoral condyle. These were reviewed by the cases that led to total joint replacement were reviewed by pathologists on the adjudication committee who found them to be consistent with end-stage osteoarthritis, a lot of bone detritus, but not evidence of a primary osteonecrosis. So it was felt that these were this RPOA, and distinguishing RPOA type 2 from type 1, where type 1 was a more rapid loss of joint space width than would be expected from the usual progression of osteoarthritis. So why is this being seen less often? I actually don't know that it is less often in the more recent trials with the subcutaneous than with the IV administration. One reason may be because of the elimination of the concomitant therapy, which was an observation in the earlier studies, again, without a good biologic explanation, except maybe that NSAIDs are known to inhibit bone remodeling and fracture healing in preclinical models. And maybe because of the so-called risk mitigation strategy, which excluded people who had existent subchondral insufficiency fractures based on imaging from enrolling in the trials. And we know from a more recent study that Jeff Katz is conducting in patients with knee pain and meniscal injury that subchondral insufficiency fractures occur in about 5% of these individuals if you actually get an MRI and have it read by a musculoskeletal radiologist. So those two things may be contributing to the lower incidence in the more recent trials than in the older trials, and also avoiding the higher doses of the NGF inhibitors.
Is that helpful to our the question?
Yes, thank you.
And then I've got an email coming in from Fiona Watt, who's good to hear from you, Fiona. She wants to know how she can get a message, how she can send a message to us. She's got a comment. Emily, can you help there?
Yes, I will message her. Thank you.
Okay. Okay, and then here's one question. If this is an analgesic, is it envisioned that it could be used as a single dose PRN? Would that be a lower dose than we think? That's a interesting question. That's from Fiona. It's an interesting question, Fiona, because when I think of PRN, I kind of think of a short-acting therapy. But I think this could be used as needed, probably with a caveat of as needed with a break of 8 weeks in between. And then the question becomes, how many times can we give it, or will it be approved to give? I mean, I could see giving it to a patient who does not respond to NSAIDs and has contraindications to other medications. And I would hope that it would work for 8 weeks and give them, if you will, reduction in pain and a pain holiday. How many times one could give it PRN safely, or would it have an effect if we continued to give it? I don't know. Anyone else? Let's hear another response to that.
Yeah, I think that's a really interesting question, because we know that most analgesics are used PRN. That PRN means lots of different things. And as Nancy said, one of the questions is, how long could you stay on treatment if you went on to anti-NGF? And that, I think we don't know at the moment. It looks as though it remains effective for a period of a year or more. If you had a flare, a flare of osteoarthritis pain, would you want anti-NGF? And I would have concerns about that, because I don't really know what the flare means. And I don't know from the data we've got whether having a flare is a risk factor for having rapidly progressive osteoarthritis if you go onto anti-NGF. So I think more research would need to be done for that. How about having it PRN because you're about to get married? That sounds reasonable to me.
Actually, it would be better for the parent who's going to dance at the wedding. But that's when we give intra-articular steroids, usually the week before they go to the wedding, so they can dance at their child's wedding. So I might comment further on that with two things. Number one, one thing we haven't done in the field of osteoarthritis is adopt a treat-to-target approach. And we could theoretically use anti-NGF compounds with a treat-to-target approach. So in the long-term safety study, subjects who did not achieve 30% improvement in pain, and there was not a target threshold there, did not continue after 16 weeks. So they stopped the study at that point in time. They were followed for safety endpoints, but didn't receive any more injections. But if you were going to consider using this on an as-needed basis, it could be done with treat-to-target, and you could spread out the injections, hypothetically, as long as the patient was in a low symptom state. Let's say had a patient acceptable symptom state and had an NRS pain level below 3. Would you want to continue treatment at that point? Maybe not. Maybe you would hold treatment until they had an increase in pain. And then that gets you to David's point about flare. And we really don't know how to define flare at the moment, but I would only say that there's an OMERACT working group which has the remit to define flare in osteoarthritis, and has actually come up with the domains that are important to patients in terms of defining flare. And now they're in the process of trying to figure out what instruments should be used in order to capture those domains quantitatively.
Thank you, Mark. I would like now to allow Ollie Gramazzi. Thank you, Ollie, for listening. He's got a question and he's going to unmute and ask his question.
Do you hear me?
Very well, Ollie, yes.
Thank you. Thanks to everybody for this quite amazing discussion. But I wanted to take actually the patient seat as suggested by David Walsh. And I am actually a patient with pain, let's say hip or knee. And I got actually to your office. It can be Mark, David Felson, David Walsh, any of these rheumatologists. Can you do the diagnosis or differentiate between osteoarthritis, a regular one, a simple one, and subchondral insufficiency fracture just on medical examination?
No.
Yeah, I was gonna, and I'm gonna second that. I'm gonna second that. No.
Yes. So my second question now, if you don't, and you said it all. I mean, Mark said that, you said that, David, first. You cannot actually, and you don't want to just give any treatment, to someone with a CIF. How can you do this if you're based really on an X-ray that will not show the CIF as well? So you don't have actually something manually or for physical examination that you can do the difference, and you don't have really the tool because X-ray will not show you that. And I'm not even going to talk about other exclusionary criteria that X-ray will not see at all. So how are we going to just do this?
So this is a really important question, really, as to how much investigation we do and how much we do things by likelihood. And the same thing that you're talking about applies also to an intra-articular injection. I wouldn't do an intra-articular injection in somebody with a subchondral insufficiency fracture if I knew they had it. So we'd be talking about time course. Is there a suspicion that, is this a flare or has this been like this for some time? One may do an X-ray, and in fact, the most recent trials, part of the mitigation strategy was to do X-rays prior to commencing treatment on the anti-NGF antibodies, okay? But X-rays are not the most sensitive test for CIFs. So should you do MRIs? And each time you do this, you're delaying the treatment and you're increasing the costs so that it's less likely to be available. And somebody at some stage has got to take the choice as to whether it's worth the risk. If it's a low likelihood of an adverse event, and you're not going to get the treatment if you have to have lots of tests to try and exclude it, is it worth just taking the risk? And everybody will take a different view on that. And that's one of the things with the patient preference studies that we were doing that was coming out, was the heterogeneity. Some people will just go gung-ho for it and want treatment, whatever the risk. And some people are really risk averse and will want to not be treated. And that's an individual decision.
Thank you.
Hi, everybody. This is Jason Kim from the Arthritis Foundation. Looks like we might have lost Nancy due to some technical difficulties, but this is also, where we begin to close the meeting down. We will be having a networking breakout session that's hosted by one of our patients, Patrice Johnson, and she coincidentally has a question for David Walsh. Maybe if David could perhaps stick around another 5 to 10 minutes afterwards, you could take it in that networking session, and those of you that are able to stay beyond that, we welcome you to hear that question and maybe pull them in for a few more questions. Thank everybody for this great meeting. Of course, thank you, Nancy, Daniel, Anne-Marie, David, Mark, and our patient representatives, of course, David Felson and Martin Lotz, Guy Eakin, and the rest of the Arthritis Foundation staff. Also, thank you, Emily and Caroline, for helping make this the logistics go through. And we also would like to announce our next session, which is Cell Therapy for OA, Potentials, Perils, and Pitfalls, and that's led by Scott Rodeo, set to take place on the 23rd, and you can find that on our website. So, please stay tuned or stay on the line for the networking sessions that will probably get triggered in the next 5 minutes or so. And I'd also like to just give a little bit of time to Martin Lotz, who's another chair of the OACS Forum Series, as well as our MSAC committee and board member. So Martin, if you could close us out, that would be great.
Yeah, I would just echo what Jason just said, expressing my thanks to the organizers, Nancy, for putting a terrific program together, also giving us her view of an experience with the NGF inhibitor trials, and Marie for setting us up in understanding basic mechanisms of pain sensation, and David Walsh. Thank you very much, Marc Hochberg, for pointing out the risks, adverse events, and the overview of clinical trials. I think this obviously was a very timely topic in view of the pending potential approval of Tanezumab. And I think this was a very instructive and informative session. So thanks, everyone. Thank you very much also for the audience for listening in and for your questions.